Good evening. I'd like to welcome you to today's ESDS webinar on extracorporeal circulation in thoracic surgery. And it's a great pleasure to have an excellent faculty with us today who will cover different aspects of extracorporeal circulation. So we will start out with Professor Elie Fadel. He's the head of the Department of Thoracic Surgery in Marie Lannelongue in Paris, and he will talk about intraoperative ACLS for extended thoracic procedures, when and why. The second presentation will be given by David Gomez. He's from Puerto Rico in Madrid. However, currently underway, so that's why, even though he's live with us, he pre-recorded his presentation, and we will look forward to hearing from him about awake ECMO. And third presentation will be given by Professor Sandra Lindstedt. She's from Lund in Sweden, and she will talk about ex vivo lung perfusion. So, as always, please ask any questions that you have in the chat or in the Q&A tool, and we'll do the discussion once the presentations are finished. So, Elie, the stage is yours for the presentation.
Thank you, Clemens. Good evening to all of you. Probably it's evening. So, and upload my presentation. I have to share. So it's okay. You see my slides?
Yes.
Okay. So question by Clemens was when and why using intraoperative ECLS for extended thoracic procedures. So it's ECLS encompasses all the modalities using extracorporeal blood circuit and oxygenation to achieve gas exchange and or cardiac support, hemodynamic support. Most commonly used in thoracic surgery is ECMO, extracorporeal membrane oxygenation, that as you see, maybe a VV ECMO, veno-venous ECMO, or veno-arterial ECMO. So we'll see all the indication and want to use them. So the main indication for intraoperative ECLS in extended thoracic procedures are lung transplantation, complex airway procedures, and extended thoracic tumors resection. The other indication are less standardized, but this is the main indications. In lung transplant, ECMO may be used before as a bridge to lung transplant, after transplant for a treatment of primary graft dysfunction, but here we talk about how to use it during the procedure. What are the main indications for lung transplant on ECMO? Routinely, it should be used for pulmonary hypertension. Patients with pulmonary hypertension, and especially severe pulmonary hypertension, those patients, ECMO, it's a veno-arterial ECMO, most of cases, because we have to fix the hemodynamic instability also, and that's why it's the veno-arterial ECMO is the standard, the gold standard for this transplant. It should be used before anesthesiologic induction in case of patients with hemodynamic instability. Those patients, because anesthesia may induce vasoplegia and induce ultimately heart failure and circulatory arrest. So those patients, we put them on ECMO, awake ECMO, immediately before anesthesia induction. In case of stable patients with pulmonary hypertension, we open the chest and we put the ECMO before the first pulmonary artery clamping. This is most of cases, but usually when they are in the OR for lung transplant, It's usually as soon as we mobilize the lung and the heart, it may induce some hemodynamic instability. So we try to do a dissection of the lungs, pleural adhesions, as much as possible before putting the ECMO, but it's very fast. We use it. For the other indication for lung transplant, all other end-stage lung disease, we use either veno-venous ECMO or veno-arterial ECMO, depending on request. In case of hypoxemia, we put or hypercarbia, we put veno-venous ECMO. But if there's any hemodynamic instability, we switch for veno-arterial ECMO. And as I told you, because of the risk of bleeding, it's necessary to perform as much dissection as possible before institution of ECMO. This is very lastly the ISHLT consensus statement of use intraoperative ECLS during lung transplant. In case of severe right ventricle dysfunction refractory to medical optimization, medical treatment, will establish medical treatment, the implementation of ECLS for intraoperative support, the strength of agreement around 100%, with a recommendation level of recommendation is of 1. Sorry, it's the class of recommendation of 1, and level of evidence of B2. It's a veno-arterial ECMO, as I told you, is the preferred choice, the primary choice for intraoperative support for a patient during a lung transplant, as compared to, of sure, to cardiopulmonary bypass and to veno-venous by ECMO, with a strength of agreement about 80%, and recommendation level of recommendation 1, and evidence B2. And it's mainly, we use a central cannulation is preferred in case of short-term intraoperative support, and if we expect that we will continue with the ECMO post-operatively, it's preferred to use a peripheral cannulation, usually femoral cannulation for those patients. So as you can see here, we can use, during transplant, we can use peripheral or central. What is the advantage of peripheral is the possibility to start pre-operatively before opening the chest under local anesthesia, no cannula in the operative field, with a lower risk of air block or major bleeding. We don't manage the large vessel into the chest, and it's easier to remove this cannula in ICU if we need to have prolonged ECMO. However, in central, there's for this patient, there's in peripheral ECMO, there's a risk of lower limb ischemia, lower venous drainage with a lot of phlebitis beyond the cannula, with a higher risk of groin infection, and retrograde flow. So it's we have a lower oxygenation of the brain in these patients compared to a central ECMO with better venous drainage and flow. Because we can use larger cannula, especially in young women and in children. No groin incision or access, with no lower limb ischemia, and anterograde flow. There's no Harlequin syndrome with the central venous ECMO. However, there's a higher risk of bleeding, major bleeding, because we deal with the large vessels. Risk of transplanted lung hyperperfusion, because we don't we discharge all flow into the pulmonary artery, so there is no perfusion of the bronchus into in the graft during the bypass, during the ECMO, sorry, and it should be removed in the OR. If you keep it longer, reopen the chest. And this is in lung transplant. For complex airway procedure, there's a very nice recent review by Clemens and colleagues on the use of ECMO during airway surgery. As you can see here, the cumulative cases of published ECMO in airway surgery had evolved very recently and increasing year after year. So this is the last 3 decades. You see the use of the support during airway surgery has increased, probably because he had improved the management of bleeding and the management of using anticoagulation in those patients. The majority are veno-venous ECMO. The most common support for to fix insufficiency of ventilation and oxygenation during the procedure. It's it's technically easier to set in place and less at risk than veno-arterial ECMO. The most commonly reported cannula configurations in veno-venous ECMO are femoral vein for drainage and internal jugular vein for return of oxygenated blood. And veno-arterial ECMO should be considered in patients with hemodynamic instability before the surgery, or who might become so during the surgery. The main indications reported are primary malignancy of the central airways, mainly adenocystic carcinoma, because they require large resection of the trachea. The second indication is malignant infiltration of the trachea by tumor of the adjacent organs, like a thyroid, like a sarcoma, like very rarely germ cell tumors. Tracheal stenosis is usually not so complex to require ECMO, but there's some teams they prefer to do surgery without any stress, so they put the patient on ECMO for standard tracheal stenosis. I will show you some cases of airway injuries, complex airway injuries requiring ECMO support, and also for congenital disease, because you will see mainly in young kids. We will discuss it later. The advantage is to avoid cross-field ventilation, avoid hypercarbia, and better exposure of the operating field. So in children, because of the small size of pediatric airways, and they have a very low oxygenation reserve, if you try to do the surgery in children with cross-field ventilation, you have to remove it all the time. So it's much easier to put the patient on ECMO, and you cannot do any surgery, any tracheal surgery in patients younger than 1 year without any assistance. It's also used in patients with compromised lung function. In very complex procedures, like as I told you, adenocystic carcinoma, you have to do resection, very large resection, and to dissect free all the airways, to do suture without tension. It's important. It's very helpful to use to do this surgery on ECMO. You use it also when you have a very difficulty to a lot of difficulties to have exposure of the site of the operating field, and when you have onset of respiratory or hemodynamic difficulty during surgery. One advice is do not wait until the last minute or until the complications arise to use ECMO. And ECLS with a perfusionist should always be available in the operating room during complex airway surgery. This is typically a complex procedure. A young patient, 40 years old, with esophageal carcinoma, not operable. She underwent chemoradiation therapy with complete necrosis of the tumor of the esophagus. They put a first stent into the esophagus and destroyed all the membranes from the cricoid cartilage up to the carina. They put another stent in the trachea, and she had aspiration. And when she was referred, she was completely exhausted, with pneumonia, with respiratory failure. So we had to manage this patient to remove all the stents, and we did a tracheostomy. We were unable to ventilate because all the membranes disappeared. So we had to put intubation in both bronchus. So we did the surgery with pneumonia, of course. We did the surgery on veno-arterial ECMO, and then we switched it for veno-venous ECMO. As you can see, the cannula into the jugular vein and the femoral vein. And we weaned this patient from ventilation and from ECMO. As you can see here, we had to put a Y stent because we had two separated bronchus. And now she's recovering from pneumonia. So ECMO was very helpful in this case to ventilate the patient and with a compromised function. Here, the same paper, you see the main kind of ECMO depending on the disease for airway indications, airway surgery indications. So most of the cases are a veno-venous ECMO, stenosis or for stenosis, and for sure for veno-arterial ECMO is more frequently used for tumoral indications or airway injuries. Probably depend. It's case by case, but it's not well standardized. When you can use veno-venous ECMO, it's better. If there's any hemodynamic instability or in kids, veno-arterial ECMO. The third indication is extended thoracic tumors resection. Why we should use ECMO? Why we should use assistance? The procedure should be performed always with a curative intent, with en bloc surgery, with a microscopically tumor-free margin. R0 resection is the goal. And under no circumstances this kind of surgery on ECMO should be done for a palliative intent. The indication is to decrease the operative risk while manipulating the heart and the lung, and to improve intraoperative oxygenation and avoid hypercarbia. To avoid also hemodynamic instability, we will see in some indication of T4 resections. When we should do it after a first step, when you do extended resection, for tumors, for lung tumor, first step is to assess the resecability, to be sure that we can do en bloc complete resection, the first step. And then after that, we can start resection and use ECMO if necessary. So we should also use ECMO after freeing all pleural adhesions or benign pleural adhesions, because it increases the risk of bleeding after anticoagulation. We shouldn't wait until the last minute or until complication arise. Often when we think about it, it means you need to do it. It's very important, because when you put ECMO in emergency setting, it's very risky, and it has been shown by a paper when it's unexpected use of for cardiopulmonary bypass, surgery on cardiopulmonary bypass. It's associated with the main risk factor of postoperative mortality during extended thoracic tumor resection. So ECMO machine should with dedicated perfusionists should always be available in the operating room during complex thoracic tumors resection. Here we have published 10 years ago our series of extended resection, T4 non-small cell resection under cardiopulmonary bypass at that time. Its main indication it was the heart, left atrium, the aorta, the pulmonary arterial trunk resection, and sometimes it was superior vena cava resection with hemodynamic instability. At that time, ECMO was not. It's a very historical series, but at that time ECMO was not as available as now, and we had only cardiopulmonary bypass. But each time we can switch for ECMO. As you can see, we will have the same result and a better here. This result of extended T4 resection in a series of around a little bit less than 400 patients of T4 disease. We have exactly the same result on when the resection was done under cardiopulmonary bypass and without cardiopulmonary bypass, and exactly the same, no difference in terms of long-term survival. So the use of this kind of devices to cardiopulmonary bypass, but it's the same with ECMO. It will not increase the risk of distal metastasis in tumoral resection. So ECMO now it's more used than cardiopulmonary bypass because you can use it for a longer time with a limited systemic anticoagulation, very low level of anticoagulation, usually 15 unit per kilo, and sometimes because all the tubing are pre-coated with heparin, we don't use when there is a high risk of bleeding. We don't give patient heparin. With ECMO, we have less activation of inflammation pathway because the blood is not in touch with the air. But in ECMO offshore, you don't have the possibility to do aortic cross clumping or open heart surgery when you have left atrium involved, or pulmonary arterial trunk or aortic arch involvement, and you don't have any backup in case of massive bleeding. So extended resection for tumor is always a balance between the operative risk and the benefit. It's very rarely used compared to the number of extended resection. Around 0.5% of all resected tumors are resected on ECMO. Typically, you have this kind of patient, young patient with germ cell tumor, referred with hemodynamic instability. He couldn't tolerate any chemotherapy. So to do debulking or to do all this mass resection, you have to have a central ECMO available. As soon as you use this kind of surgery, we do it on with a clamshell incision. But as soon as you free the heart, you may have a decompensation of the hemodynamics. So this kind of surgery should be done with the ECMO available on the OR. This is a different kind of cannulation site according to the incision. In case of sternotomy, the best way is right atrium ascending aorta. In case of right thoracotomy, we have the same cannulation site, right atrium and ascending aorta. In case of left thoracotomy, it's interesting. It's better to put a venous cannula into the femoral vein and put the aortic cannula into this descending aorta because it's in front of you. In very rare case, you can put the venous cannula into the main pulmonary artery, but because of the lung resection, it's sometimes difficult. For clamshell, the same, right atrium and ascending aorta. This is the kind of tumor that you cannot resect with ECMO when you have the left atrium involved, like here, in this patient, or the main pulmonary arterial trunk involved, like here. So it's better to do it on cardiopulmonary bypass. For the descending aorta, depending on the level, so we continue to do it under partial cardiopulmonary bypass because of the risk of bleeding. But now we have the TVAR, the under-aortic graft available that may help to manage bleeding in this kind of patients, because usually you don't have to resect all circumference of the aorta. So if you put an endograft, you may have a local control of bleeding, and with ECMO available, because it's just an assistance, a partial assistance, and that's enough to repair the aorta. So, in conclusion, ECLS can be performed safely in the perioperative period for extended thoracic procedures, and always and allows marginal patients to be operated on. With technical advances in ECLS devices and growing surgical experience, ECMO took over and cardiopulmonary bypass, and was increasingly used, as it showed significantly fewer associated operative risk compared to cardiopulmonary bypass. When deemed necessary, ECMO should be used early, before the onset of respiratory and or hemodynamic failure. Also, a rare indication, ECMO should be part of the surgical armamentarium for teams who deal with frequently with extended resection for the treatment of non-small cell lung cancer. Thank you.
Thank you, Elie, for this very comprehensive overview. So we will proceed now with the pre-recorded presentation of David. Elie, if you can stop sharing your screen, I will put this presentation on.
Good afternoon, dear colleagues. It's for me a great pleasure and an honor to participate in this ESDS webinar about awake ECMO strategies. I would like to express my deep gratitude to Dr. Aigner and the rest of the members of the organizing committee for the kind invitation. I have no conflicts of interest to disclose relative to this topic. I will be discussing some practical aspects, limitations, and recommendations regarding awake ECMO as a bridge for definitive therapy or recovery. This is a graphic from ELSO registry showing the exponential increase in the use of ECMO as a rescue therapy for all indications since the early 2000s. With such big numbers, it seems very relevant to optimize care of these patients in order to improve both short and long-term outcomes. Mechanical ventilation, sedation, and muscle relaxation inevitably leads to the obscure and ominous land of the upside down, which translates into the conditioning of the patient, lung injury, risk of pulmonary complications, prolonged ICU and hospital stay, and a devastating and severe impairment of patient recovery. In the field of perioperative thoracic surgery, there are two main indications for ECMO. First, cases of severe respiratory insufficiency after lung resection or any other thoracic surgery. And second, as a bridge to definitive therapy in cases of end-stage lung disease. Most of my talk will be focused in this last scenario, although the same principles should guide for ECMO management in cases of adult respiratory distress syndrome. The frequency of ECMO bridge to lung transplantation has steadily increased since the implementation of the lung allocation score in 2005, and also with technical improvements in membrane lung devices, components, and circuits. Data from retrospective series and registries show an incidence around 12% of listed patients being bridged with ECMO, with a failure rate oscillating between 50 to 30% and a survival rate after a successful bridge ranging from 50 to near 90%. ECMO has traditionally been a rescue therapy when mechanical ventilation was not enough to keep the respiratory status of a patient with severe compromise. Nowadays, ECMO only as a bridge is actually surpassing ECMO plus mechanical ventilation as the strategy of choice. These are data from UNOS registry up to the beginning of 2023, and you can see in red the progression of the percentage of patients bridged with ECMO only compared with ECMO plus mechanical ventilation. It seems clear that being awake and even ambulating while on ECMO, has significant beneficial impacts on our patients. The aim of a bridging therapy is to gain a precious time to optimize patients' nutritional and physical condition in order to successfully overcome the transplant or fully recover previous health status. To this end, it is essential to keep the patient awake and off mechanical ventilation if feasible, actively collaborating in his or her rehabilitation, like sitting in bed, standing up, or even walking. This is not always easy and requires a high level of commitment and collaboration from all specialists involved in patient's care. The cornerstone for succeeding in the attempt to keep the patient awake under ECMO is a highly motivated and experienced multidisciplinary team with specific and predefined tasks. Apart from the attending physician responsible for the patient care, it is of utmost importance to apply valid and reliable standard assessments to evaluate patients' ability to actively cooperate. Pooled data suggest that keeping the respiratory distressed patient under mechanical ventilation in the ICU around a score of 0 in the Richmond Agitation Sedation Scale is a desirable goal in terms of risk of death, delirium, and delayed time to extubation. Other useful tools when deciding and planning the strategy for the patient's awakening are the confusion assessment method for the ICU to evaluate delirium, and of course, any validated instrument to assess patient mobility and gait. For example, the bedside mobility assessment tool shown in this slide. To reach these goals, there is a clear recommendation for optimizing pain control and anxiety of these patients. Sedative and analgesic practices are highly variable among ICU departments, but an infusion of remifentanil, a short-acting opioid with or without low dose of propofol, are the preferred choice most of the cases. In some protocols, dexmedetomidine can also be a valuable alternative, and there's no doubt that a comprehensive and multimodal approach for analgesic control is mandatory. The next step before any attempt to mobilize the patient on ECMO is to secure cannulas with cutaneous sutures or adhesive anchors, as well as to test a stable flow at 90 degrees flexion on the hip in case of a femoral ECMO configuration. Our target is to keep the patient awake, and for this, the ultimate goal should not be to reach the maximum levels of oxygenation in blood. We should tolerate certain levels of hypoxemia, provided that there is still an adequate tissue oxygenation in the patient. The initial phase focuses on passive range of motion exercises performed in bed, with careful attention to maintaining stable ECMO flows and preventing cannula displacement. Then, if the patient shows tolerance to these activities, the second phase introduces assisted sitting positions, requiring a complete coordination between physiotherapy staff and ECMO specialists. Then we can advance to supported standing exercises, necessitating a careful preparation and positioning of the ECMO circuit to allow for patient verticalization while keeping adequate flow parameters. And the final step culminates in ambulatory activities, which require a dedicated support team, typically consisting of a physiotherapist, an ECMO specialist, a critical care nurse, and also a respiratory therapist in case of a tracheostomy ventilated patient. Ideally, we would like to keep all of our ECMO patients awake and off the ventilator. This is not always the case, not only because of a lack of qualified personnel for such tasks, but also due to the patient's underlying conditions, comorbidities, and individual characteristics. In some cases, The intense respiratory effort required to remain awake and without support leads to an excessive driver pressure, causing the so-called self-induced lung injury syndrome. Furthermore, the respiratory effort also increases oxygen demands, making it necessary sometimes to keep a continuous adjusting of patients' hemodynamic and respiratory parameters. In addition, it must always be borne in mind that the clinical condition of this type of patients can suddenly change, and the possibility of requiring an emergency intubation is ever present. The earliest clinical reports, foundational to current experience with the awake ECMO strategy and acute respiratory syndrome, and as a bridge to lung transplantation, were published in the early 2010s. They consisted on single-center experiences and established the safety, feasibility, and potential benefits of awake ECMO, including reduced sedation, shorter postoperative ventilation, and improved early mobilization. In light of these previous experiences, many centers have now incorporated an awake ECMO strategy to their protocols. And there are a considerable number of studies so far that strengthen this approach. In this retrospective study, including all ECMO-bridged patients registered in UNOS database from 2005 until 2023, early and long-term outcomes were analyzed, comparing ECMO only versus ECMO plus mechanical ventilation, before and after adjusting for prognostic factors, and authors found out that patients in ECMO only bridged group were more frequently extubated in the first 3 postoperative days, with shorter length of stay and a better 90-day survival rates, showed in this Kaplan-Meier curve. A recent retrospective analysis, again from the UNOS database, shows that survival in ambulatory ECMO-bridged patients is superior to the non-ambulatory group, as you can see in these graphics. In the green line, patients unable to ambulate while on ECMO. The 90-day waitlist survival was the highest among the non-ECMO group, but both ambulatory veno-venous and veno-arterial groups had superior survival compared with the non-ambulatory group. The first year post-lung transplant survival between non-ECMO and ambulatory veno-venous ECMO was comparable. We can affirm that ambulating patients or use of physical therapy while on ECMO can help improve lung transplant outcomes. To conclude, keep your patients awake and active during ECMO. Understand the physiologic drivers to the patient's condition and discuss the plan in a multidisciplinary team involving physicians and specialized nurses. But be aware of your own logistics and manpower limitations. Maybe the best you can get is to keep the patient awake, exercising in bed, and that is far better than nothing. Thank you very much for your attention, and I remain at your entire disposal to any question that may arise. Thank you again.
So let me just switch to the video.
This was just a video of one of our patients in the ward, ICU ward, doing standing exercises. Thank you for your attention.
Thank you, David. And now we move on to Sandra's presentation to a very special form of extracorporeal circulation, ECLS on an isolated organ.
Thank you so much for that introduction, Professor Aigner, and thank you so much for the organizers to invited me to this session. And I will be talking about ex vivo lung perfusion, EVLP. So these are my disclosures. So lung transplantation is the only treatment option for patients with end-stage lung disease, but unfortunately not enough organs. And only 10% of the global need is met, and that results in death on the waiting list. So why is then this case? Why don't we have enough of donor organs? Well, a lot of donor organs cannot be used due to lung injuries, and we turn down up to 80% of all donated lungs. So lung transplantation, if we start from the beginning, involves a number of key steps. First, the donor lungs are taken out from the donor, and then before they put in the recipient, then we can do ex vivo lung perfusion to evaluate the donor lungs again. So EVLP was developed to be able to evaluate lungs outside the body, and having like a perfused and circulated circuit and ventilate the lungs at the same time. And this is a very old video, and it's from Professor Stig Sten's lab in the late 90s. Professor Stig Sten was the one who developed the ex vivo lung perfusion, and it was further then I would say spread around the world efficiently by the Toronto Lung Group. And as you can see here, in the beginning, we used the heart to cannulate the lung because we didn't think that anyone would do DCD heart at that time. Of course, that would not be the case now. So then you can prime this circuit with or without the blood. So then you keep the lungs in sterility, and as you can see here, perfused. And when the lung has then reached between like 34 to 36 degrees, you can start to ventilate the lung. And you can see here how the lungs soon start to become ventilated. So you can see here. So this is a very, very old device that is not used nowadays. And there are several of devices on the market. And here are just some, and there are many more to come. So when it's come to clinical EVLP, there are three main protocols. The Toronto protocol that is the mostly used, and the Lund protocol and the OCS protocol. So there are all protocols have been used in clinical trials, and they show safety and good results. But the protocols are different in a few ways. It's how you composite the perfusion, how you main the flow strategy, how you manage the LA, and also the duration of the whole EVLP. So when is EVLP useful then? Well, if you cannot evaluate the donor lungs within the donor in an optimal way, then EVLP is a good way of reassessing the lungs. And before we said for logistical reasons as well, and then this whole 10-degree came, and I think there's fewer and fewer people now using EVLP as logistic reasons. So which lungs are we going to put then on EVLP? Well, the classic one is the one who has a low PO2 ratio, but also the one with a lot of edema, neurogenic, hydrostatic edema, but also the one with bad compliance. If they have minor or moderate aspiration, it can also be it's also good to put them on EVLP and see how severe that injury is. So which lung are we not then going to put on EVLP? Well, if they have an irreversible lung injury, there's no point of putting it on the EVLP. If there's trauma with hemorrhage, there's just no use for EVLP. If there are lower pneumonia, also not any case for EVLP. And if they have severe aspiration, if there's persistent gastric contract despite repeated bronch, then there's nothing that you should put on EVLP. So when you then assess the graft, so then there's a lot of you would sort of think that, okay, if we put it along on EVLP, it's just one measurement we can use and then we know it's good to go or not. It's not that easy. we have to evaluate the physiology, the oxygenation, the PA pressure, and the airway pressure over time, and also the mechanistics, how is the compliance over time, and also edema, the weight of the lung, and if you have to increase the volume in the circuits to be able to keep a flow. And also visual inspection of the lung. There are some biomarkers that are coming like IL-6, IL-8, and cell-free DNA, but they also have to be used in conjunction with the other measurements. So what are the roles of EVLP in DCD lung? Well, a rather old guideline has been that 60 minutes of functional warm ischemic time can result then in thrombosis, and those lungs should be put on EVLP. The guidelines is based on this expert consensus from 2019. And today there are many centers who never put DCD lungs on EVLP. And there are some centers that put all lungs on the EVLP. And a rather interesting study from Professor Sarg in Paris, who was presented at the ESHLT just a few weeks ago, showed that DCD lungs put on EVLP had a better outcomes than the one who was not put on EVLP. So how should we then think about DCD lungs, and when should we put them on EVLP? Well, a good sort of consensus is, and this also supported by the AATS consensus that was released last year, is that the ones that you think that going to go, the DBD donors that you want to put on EVLP, use the same one for DCD lungs. So what treatment options do we have on EVLP? Well, the use of negative pressure ventilation has shown to be the most beneficial ventilation mode to mitigate edema, especially over time. But this is complicated and cannot be done with all devices. Another way is to prone the lung, just to switch it like back and forth a few times during the run. That's also been shown to mitigate edema very elegantly here by the Löwen group. So connecting cytokine absorption to the EVLP circuit has also been shown to mitigate infection, as here in this preclinical study. And if you wonder if the pig lungs used in this study was really injured before we treated them, you can see that we emptied the fluid here is from the trachea. On the back of the EVLP, we emptied around 1 liter of fluid from each run. And the treated one did better. This has also been shown to have an effect in the clinic by Dr. Buffini, who did this study where they treated with or without cytokine absorption and had a positive outcome. Something that is very sort of popular today is to treat with mitochondria. Just now it's just in a sort of preclinical mood, but to mitigate ischemia reperfusion injury. So if you isolate mitochondria, give them during EVLP, they actually have a much better outcome. And if you then wonder, okay, can we just isolate mitochondria, just put them in the EVLP circuit, and then they magically then taken up? You can see this live imaging. The red one is the mitochondria, and the green and the blue is the cell, and you can see how they first just go into the cell, and then to the right you see how they distribution along the cytoskeleton elements within about a couple of minutes. So another very interesting study is this from Toronto. So ABO, blood group matching, is a key challenge in lung transplantation. And they used an enzyme to then switch a lung to a zero lung. And they did this with 97% effectively. And we hope to see this in a clinical trial very soon. So EVLP has changed the lung transplant community. Although the use of EVLP has become more widespread within the past decade, not all transplant centers utilize it. There are still some barriers related to the infrastructure and expertise that are required to develop an EVLP program. In this study, it's what's shown if a center is doing below 25 to 30 cases a year, the outcome negatively impact. And that started a discussion about Should all do EVLP, or should we centralize the center? So to understand the future of EVLP and its impact on centralization center, we must first consider the current paradigm. So the current lung transplant process involves harvesting the donor from the organ from the donor at one location and transplant it to the recipient. And at that stage, a center may then decide to use EVLP or not. However, then the implementation of EVLP requires specialist infrastructure, staff, and financial investment. And for centers, especially with low volume, this is extremely challenging. So centralized EVLP then it can be used like this. So a center that is then, centers are sending it into a center, and then when it's evaluated, it's sent back to the centers for a transplant. What are then the benefits? Well, it's a high efficiency, and it's good financially, especially then for low volume centers. So in this study, there were 7 centers that went together, and they looked at if centralized EVLP lung would have the as good outcome as lungs done at a high volume center. So 7 centers, 750 miles in between, and all send their lungs to this facility in Maryland. And they did 150 recipients, and then during this run, they had everything were run the same way with high experienced people. And then the lungs was sent out again. And what they then could conclude, well, the primary endpoint was they looked at PGD grade 3. They also looked at 1 month mortality and 1 year mortality. And what they could see that the ones that was evaluated as at the centralized center, they had a higher rate of PGD3, but the 30-day mortality was equal. And it started a discussion if this EVLP edema is a new form or a different form of PGD, like a phenotype of PGD. So having this in mind, and this done in the US with a third party, we started to look if this was also could be done in Europe with the healthcare we have. So this is the bridge called Lung for Life. It's a Scandinavian collaboration between Lund and Copenhagen, who established a centralized EVLP platform. And this was then supported by EU funding. And by creating this center, we have then been able to increase our numbers and also to go together with the same protocol. So the first lung that was done and transplanted cross-border was 19th of May in 2024. Since then, we've done quite some lungs. And then in January this year, we did 4 in 1 month, which is quite a lot for our centers. And they have had very good outcome. And this center is then run by my Danish colleagues and myself, Hasse Sørensen and Michael Piersch. So to the conclusion, so EVLP increases the number of transplantations. And if you think of using EVLP, well, in which kind of lungs is it? Well, if the lung cannot be evaluated properly in the donor, then it's a good way of using EVLP. Logistics, perhaps not nowadays, but some people still use it. And then when you're going to evaluate it, you have to use different parameters, not just rely on one. And EVLP should not be used if you have a severe aspiration or structural changes in the lung, like irreversible structural changes. And the use of EVLP in donor DCD lungs should be used the same as in DCD lung, at least for now, but we're looking forward to see more results from France, and perhaps we will in the future just completely change our strategy. And to centralize EVLP for in the number seem to be the way forward. I would like to thank you all so much for listening to this presentation. And again, thank you so much for this invitation. Thank you.
Thank you, Sandra, for this detailed overview on EVLP. So there's a question, which is an ideal situation where you would prefer double lumen cannula instead of two venous cannulas? This is probably for Elie or David.
Double lumen cannula, it's really interesting when you can assess the position of the cannula in a patient stabilized, like putting an ECMO on bridge to transplant. So you have the time to put the cannula and to ensure that the good hole is in front of the good cavity. This is because we don't have a excellent stabilization of this kind of cannula while you are doing procedure intrathoracic surgery. It's good for transplant. It's not good for tumor resection. It may be interesting for even for tracheal surgery, complex tracheal surgery, because you put it in the neck. So usually you have to have access to the neck for tracheal surgery, for airway surgery. So it's not a good option. So I'm quite disappointed by the double lumen cannula and other indication on transplant. I don't know if you have the same feeling.
Yes, we used it years ago as a bridge for lung transplantation, but we did not feel very comfortable with these cannulas. And when with the awake patient and mobilizing the patient, it's a very sensitive cannula. It's a little bit out or too deep inside, then it won't work properly. So you have to be very experienced and have a very wide experience with these double lumen cannulas to use it more frequently.
I also have the same experience with those cannulas as you have. So and we also not use them that much.
Okay, it's interesting to hear because we use them quite frequently. The main cannula we're using is the Gresham, and this works actually quite well in the setting we're having. But it's, of course, it has to be placed properly under appropriate guidance, and but it's so it's apparently varying from center to center. So, Elie, you've shown that there's a lot of difference between veno-venous and veno-arterial, and in the retrospective series, it's somehow back and forth. So, when we're talking about thoracic procedures without clear need for hemodynamic support, like it would be in aortic surgery, for pure airway surgery, what would be your preferred option?
If it's only for airway support, for mainly for carina resection or carina reconstruction for tumor of the carina, I think veno-venous ECMO is really interesting because you don't need so much to manage it. You put a cannula into the jugular vein and the other one in the femoral vein, and you can do all this kind of surgery safely without any and pull back on the tube on the cannula just after the procedure. It's really interesting. But when you have to put a patient for instabilities, when you are doing like carina resection through a thoracotomy, and you have the difficulty to achieve oxygenation or to fix hypercarbia, so it's so easy and so fast to put a veno-arterial ECMO in a thoracotomy, and it may manage all the consequences of hypoxia. even if you have to stabilize in terms of hemodynamic, and even if you don't need to stabilize the hemodynamic. So my option is for very short ECMO. Veno-arterial ECMO is very good and very fast and without any complication. And if in very stabilized patients while doing resection, veno-venous ECMO second option, because most of the time you have to push on the tumor, to have to push on the heart, and you have some hemodynamic instability, and you ask the anesthesiologist, they say they are already on Levofed, and
Can I ask you, when you do those kind of procedures, do you what kind of do you use heparin, and then how much, or how do you manage it with ACT, or how do you do?
For a tumor, for thoracic tumors, we give them like a vascular dose, 50 units per kilo once, and that's it. And if there's a lot of adhesions, we don't give them any zero anticoagulation.
You're doing the same?
So we actually don't do so many resections with ECMO, but then so we don't have so much experience on that from my center.
We try to we don't do cases for lung oncological cases for with ECMO, but in lung transplantation we perform almost 90% of our cases under ECMO, and we try to avoid anticoagulation, but our anesthesiologists won't go through that, so they always give the patient 0.4, 0.5 per kilo heparin, and they tailor it to the ACT levels, which sometimes they repeat the dosage. So we try to. We know that there are groups running intraoperative lung transplant support on ECMO without anticoagulation at all, but we have not done that before so far, unless it's a severe case of high risk of bleeding. That's our current protocol.
And what ACT do you aim for in those cases, or as low as possible when?
Yes, as low as possible. 160, 100.
Avoiding ACT measurements by the anesthetist.
Yeah.
Should be adapted to the bleeding situation. The patient I showed you with a large fistula, esophageal fistula, with no more membranous. So she remained 3 days on veno-venous ECMO without any anticoagulation, because she had some bleeding in the mediastinum. That's why we.
Yes, in the immediate postoperative period, it's quite usual that we don't use any anticoagulation at all. But in the intraoperative field, they always want to chart a patient with a bolus of heparin and then titrate it. And Elie, do you routinely use veno-venous ECMO for intraoperative support in lung transplantation if the patient has no secondary pulmonary hypertension? Or
in some cases of fibrosis without pulmonary hypertension, yeah, we use veno-venous ECMO for those patients. But most of cases, I would say 80% of our patients, even if there is no major pulmonary hypertension, because when you have hypoxia during the procedure, at the end you have hemodynamic instability start. That's why we prefer to do veno-arterial ECMO, so we can go on the left side. In our patient, you was talking about double thoracotomy without a clamshell incision, without a sternum slit. We never do a clamshell incision here. We never. Even if we have to put the patient on bypass, we do it through the thoracotomy. We never. Probably very few cases, but it's not the routine double thoracotomy.
Sandra, you've nicely shown the centralized EVLP, that it's also feasible in Scandinavia at least. In Europe, there's of course a lot more heterogeneity compared to the US. Do you think this model is feasible outside of an EU-funded project? And what do you think would be the necessary prerequisites to establish that in other settings?
It's a great question. I mean, I know that Professor Saag has managed to evaluate a lot of donor lungs in his center from a lot of other centers in France, and there are some other centers that now try to also centralize. I mean, we were extremely fortunate to get this EU grant to be able to establish the center. But it's complicated because it has to be built then on the trust or sort of balance between the hospitals, and I think it would be ideal to be able to have it as a third party, as a company based, as it is in the States, but it was at the present, at least, it's not possible in Scandinavia. If it's possible at other centers in Europe, well, perhaps. I know there are some sort of startup companies when it comes to abdominal organs and machine perfusion, but let's see what the future brings. But I think there's a lot of I know it's a lot of people who works towards ARCs and decentralized centers of all perfused organs.
We use in Paris. In Paris, there is 3 departments doing a lung transplant and 1 smaller department for children, 3 large departments, and we used to do around 15 cases a year of EVLP. The other centers the same amount, and finally Foch used to do more, around 30 cases. So that we centralized all our cases in Paris because it's easy. We have the same transportation for organs, so it's done in one center, and our fellows go there, and they do the EVLP in Foch. So it seems to be very economical good aspect. Yeah, economical aspect, and also for it's helpful for research.
I think it's also good to include, like you say, that the fellows go with and they learn how to do it and so on. So it's inclusiveness to spread the knowledge and work together. And that gives a good platform for research and collaboration and basically a better united community.
Yeah, it's important.
You've also shown beyond the mere re-evaluation a lot of potential approaches for therapies. Can you speculate what type of therapy might be applicable in the close future on a broader scale beyond the mere evaluation?
I mean, if I could if I would know, I would, then it would be amazing. No one knows, of course. The treatments that are closest to that already are on the market will, of course, be easier to test. One way of being able to test therapies is also by going towards centralization, where the numbers can come up. Because without the increase in number, we have a problem to test all those treatments. There are some treatments like devices connected to the EVLP, like cytokine absorption, for example, that there are now sort of companies on the market that have this as a regular treatment. So I will say that is the closest to the market. If that is the best, that will, future studies say. I think there are many I think the biggest potential lies in the gene editing of the whole lung, to be able to immunomodulate the lung to fit the recipient better and to have it so the long-term, both short-term and long-term results could be improved. But when it comes to gene editing of the lung, well, then we we are quite some years until this can be clinical adaptable in clinical settings.
Yeah, there's this broad range of research going on in that direction. So,
absolutely, yeah.
I have a question to David. When you have patients referred for lung transplant and you need to bridge them for transplant, well, usually when you need to bridge them for transplant, they are most of the time exhausted and difficult to move them. So when you put ECMO on those patients and you want to rehabilitate them, it's very difficult. It's very difficult because you have it's not only the lung function; it's the whole patient without any muscles to move. How do you manage? Do you have a team dedicated for physiotherapists dedicated for those patients?
Yeah, that's a very good question. We try not to reach that severe stage of the disease when it's our own list patient. We follow them closely. So when they are declining and they are so suddenly ill, then they are admitted, and we try to put the ECMO when with the patient awake, so he won't be so deteriorated. The problem is when we receive a patient from another center that they have been trying to recondition the patient with the tracheostomy, or they couldn't awake the patient, so it's under mechanical ventilation for several days. That is the real challenge, and we try to, if there's enough, it's a young patient or otherwise health patient, we try to again awake the patient and try to move them, unless in the bed, to do morning and afternoons exercises with them. The aim is not to get them ambulating in the ward. If we can do that, that's perfect, but just to keep them doing some exercises and with oral intake and to improve nutrition status for several weeks until the lung transplantation becomes a reality. Yeah.
Yeah, so we are already beyond time. Even though there's a lot to discuss, we have to finish for today. I would really like to thank all of you for the excellent presentations, for the vivid discussions, and yeah, the audience for the participation, and hope to see many of you at the upcoming ESDS meeting in Athens. Thank you, and enjoy the rest of the evening.
Thank you.
Thank you very much.
You.